Dear colleagues, in partnership with the Société Francophone de Nephrologie, Dialyse et Transplantation, die Österreichische Gesellschaft für Nephrologie und die Deutsche Gesellschaft für Nephrologie, Marcus at Home welcomes Professor John McMurray in Glasgow, Scotland, UK, with whom we would like to discuss novel developments in the treatment of heart failure, particularly heart failure with reduced ejection fraction, HFREF, in the aftermath of this year's ESC convention, which took place a few weeks ago in Madrid, Spain. Dear Professor McMurray, dear John, we are really honored and blessed to host a global leader in the true sense of the word of cardiology at Marcus at Home.
Well, thank you from my side for joining, Professor McMurray. Just as a brief introduction, I don't think that's really needed. John McMurray is currently Professor of Medical Cardiology and Honorary Consultant Cardiologist at the Queen Elizabeth University Hospital in Glasgow. He has served as the inaugural Eugene Braunwald Scholar of Cardiovascular Disease at the Brigham and Women's in Boston, Massachusetts. Is also visiting professor there. He's past president of the Heart Failure Association of the ESC. Professor McMurray has received an outstanding number of awards really for his work and titles, and has shared and hosted and written so many publications. I think his Hirsch index is above 200. So that is really an honor for us to have you here. Well, that's enough of our introduction. If you could, John, please, we thought if you could, as you did at the ESC conference, share your thoughts on the Victor study and vericiguat, and we would, if you agree, also extend these thoughts possibly to other options of novel treatment in heart failure. We heard some new data on Digitalis. I'm sure you have some thoughts on this as well. So looking forward to what you're telling us. Thank you.
Thank you very much, Stefan. I'd be delighted to do that. And so I'll start with a commentary on the Victor trial, and then we can talk later about Digit and digitoxin. So Victor was a trial that we've been waiting for a very long time, and really one that is very important, and as it turns out, one that I think caused a lot of puzzlement when it was presented. And this story really goes back to 2020, and that's why we were waiting for a long time for the results of Victor, because it was preceded by a trial called Victoria. And Victoria was interesting because it was a trial using a completely novel type of drug, a soluble guanylate cyclase stimulator, so a drug that acts by stimulating this intracellular enzyme, resulting in an increase in cyclic GMP, and the downstream effects of cyclic GMP are theoretically beneficial in patients with heart failure. Now, one of the things that will run through this presentation is the fact that we know of other agents, of course, that act through cyclic GMP, and in the heart failure arena, probably the one of most interest is sacubitril, or the neprilysin inhibitor that we use in combination with valsartan, and natriuretic peptides acting through the A receptor on the cell surface also augment cyclic GMP, although they do that through a different cyclic GMP pool. But we do have another proven therapy for heart failure that acts through cyclic GMP. So the Victoria trial, the original of the two trials, which, as I said, presented back in 2020, was a little bit different than other trials, and this became an important consideration. Different than other trials we've done in HFREF, because it required patients to have had a recent heart failure hospitalization or equivalent, an episode of worsening heart failure. And indeed, patients were enrolled often when they were still in hospital in this trial. And in addition, and unlike other trials in HFREF, the Victoria trial required patients to have a really very high natriuretic peptide level, the NT-proBNP level. in patients in sinus rhythm had to be at least 1,000 picograms per mil and considerably higher in patients with atrial fibrillation. So you can see here a comparison of some of the other aspects of the Victoria trial design to two of the very positive trials that we had led in patients with heart failure and reduced ejection fraction. So I've mentioned NT-proBNP, blood pressure was a little different, EGFR was a little different, and then of course, as I just described, all of the patients in Victoria, unlike patients in Paradigm and DAB-HF, had to have a recent heart failure hospitalization, and indeed, as I mentioned, in some cases, patients were actually enrolled, randomized in Victoria when they were still an inpatient. And as a result, the patient characteristics looked a little bit different. NYHA class was a bit more advanced in Victoria than in some of our previously successful HFREF trials. Of course, the median NT-proBNP level was much higher, and so on. So the patients in Victoria were a little bit different. And that became a consideration because of the results of the Victoria trial, because unlike the trials that we'd done with sacubitril/valsartan, or the two large recent SGLT2 inhibitor trials in patients with heart failure and reduced ejection fraction, the results of the Victoria trial were maybe a little bit disappointing. The relative risk reduction was only 10%. The hazard ratio was 0.90. And although that was a statistically significant benefit, it was rather small compared to the larger relative risk reductions we'd seen with other therapies in patients with this type of heart failure. And as I said, that became a consideration when we delve into these results further, and when we look at the trial that was just presented a few weeks ago at the ESC. So when the Victoria trial was investigated and analysed in further detail, you can see two interesting findings summarised in this slide. If you look at the top panel, you can see the effect of vericiguat examined according to baseline NT-proBNP level. So this histogram shows you the distribution of NT-proBNP at baseline in the Victoria trial, and the solid orange line here shows you a continuous hazard ratio, which was below 1, as you can see over here to the left of the figure, in patients with lower NT-proBNP levels, but you can see was actually above 1 in patients with high NT-proBNP levels. And maybe consistent with that, you can also see here that the continuous hazard ratio for the effect of vericiguat compared to placebo was below 1, in other words, indicative of benefit of vericiguat in patients who were remote from heart failure hospitalization. So the more days since heart failure hospitalization to randomization, you can see the more favorable the treatment effect. Patients who were randomized close to a heart failure hospitalization, the treatment effect was a lot less. So one of the considerations after that initially disappointing result of the Victoria trial was that perhaps the patients enrolled were too sick, were too acute, were too unwell to benefit from vericiguat, and maybe the effects of vericiguat might be different in a different population, might be more favorable in a population that looked more like the patients that we'd enrolled in previous trials with heart failure and reduced ejection fraction. For example, the Paradigm heart failure trial with sacubitril/valsartan, for example, the DAB-HF and Emperor reduced trials with SGLT2 2 inhibitors. So the Victoria investigators and the sponsors carried out a second trial with vericiguat, and that second trial was called Victor, and this was the trial that caused so much interest at the recent European Society of Cardiology Congress. So once again, it was comparing vericiguat to placebo. Once again, it was a big trial, 6,000 patients, but this time the patients were chronic ambulatory HFREF patients, very similar to those enrolled in our other recent successful HFREF trials. So mainly class 2 and 3 patients, patients with an ejection fraction of 40% or less, patients who had not had a recent episode of worsening heart failure, for example, leading to hospitalization, and patients with very elevated natriuretic peptide levels were also excluded from the Victor trial. These are some of the baseline characteristics, but I just want to emphasize what a good job the Victor investigators did in enrolling patients who were extremely well treated. We've really not seen patients as well treated as this in any previous HFREF trials, with universal use of beta blockers and RAS blockers, but also a very high use of sacubitril valsartan and a very high use of SGLT2 inhibitors, and indeed quite a high use of devices compared to previous HFREF trials. So this trial really was designed to test whether vericiguat added to the best available therapies we have could further reduce morbidity and mortality. So the Victor trial was published online in the Lancet simultaneously with the presentation at the European Society of Cardiology. So really a very impressive and absolutely impressive trial, and absolutely the right thing to do to test that hypothesis that vericiguat might be beneficial in a different population, to test that hypothesis prospectively. So this was the pre-specified analysis plan. So the primary composite endpoint, really a very standard primary composite endpoint for HFREF trials these days, was tested first. And if that was shown to be significant, then the investigators could go on to test the 2 components of that composite endpoint, and they could also go on to test the secondary outcomes in the hierarchy shown here. So what happened in Victor? Well, it was again a surprise. So vericiguat continues to surprise because the primary endpoint was not significant. You can see here that the hazard ratio was 0.93. The upper 95% confidence interval crossed 1, and the p-value was 0.22. So actually, in theory, we should have stopped any further examination of the Victor trial at that point. And again, just to compare Victor to Paradigm, that other type of treatment acting through the same second messenger, you can see here that in Paradigm, for the same composite outcome, it was a very different result. There was a 20% relative risk reduction, just for comparison. So as I said, really, after failing to demonstrate a significant benefit in the primary endpoint, all these additional analyses were now exploratory, but I think they are worth looking at, and you'll see why in this next slide. And the surprising, at least initially, finding in the Victor trial was that when the 2 components of the primary composite endpoint were looked at, in other words, cardiovascular death alone and heart failure hospitalization alone, we can see here that there was a nominally significant 17% relative risk reduction in cardiovascular death, but no significant reduction in heart failure hospitalization. And again, for comparison with a typical positive HFREF trial on the right. You can see here the paradigm heart failure trial with the effect of sacubitril valsartan, neprilysin inhibition on cardiovascular death and on heart failure hospitalization. So we were seeing something very unusual here, a reduction in cardiovascular death without a reduction in heart failure hospitalization. And that really, at least initially, I think, surprised everybody. But I think there is an explanation for this. I think actually it's probably, when we go into the data in more detail, maybe not as surprising as it first seems, because in fact, in the Victoria trial, that's the trial published in 2020, there was a modest effect of vericiguat on heart failure hospitalization, but it was rather small. It was a 10% relative risk reduction, not the 20% relative risk reduction that the Victor trial was powered to show. And in the larger Victoria trial, with a very large number of heart failure hospitalizations, a total of over 1,400 heart failure hospitalizations, it was possible to demonstrate a significant effect of vericiguat on heart failure hospitalization in the Victoria trial. But the Victor trial was a smaller trial and had a total of only 690 heart failure hospitalizations. Now that's enough to show a large treatment effect, for example, as we saw with an SGLT2 inhibitor in the DAPA heart failure trial, but not enough to show the rather small effect that vericiguat has on heart failure hospitalization. So really, the lack of effect on heart failure hospitalization in the Victor trial was simply an issue of numbers, was to do with the statistical power of the trial. And the Victor investigators looked at an exploratory expanded heart failure endpoint, this time including not just heart failure hospitalization, but episodes of worsening heart failure that were treated in the outpatient setting with intensification of oral heart failure therapy. And with that expanded endpoint, which you now see includes a much larger number of events, in fact, an almost identical number of worsening heart failure events as in the original Victoria trial, you can now see that there was a nominally significant 10% relative risk reduction. So I think it is pretty clear that vericiguat does reduce worsening heart failure events, but the treatment effect size is rather modest. You can see here a hazard ratio of 0.90, as I said, consistent with a 10% relative risk reduction. If you compare that, for example, to the paradigm heart failure trial, the effect of sacubitril valsartan on heart failure, worsening heart failure events was about twice as large. In other words, around a 20% relative risk reduction. So it's really just a power issue, and vericiguat, I think, does reduce the risk of worsening heart failure events. But that does leave the remaining, again, seemingly puzzling finding of a reduction in cardiovascular mortality that seems to be larger than the reduction in worsening heart failure events. And we've really not seen that with any other treatment. And here you can see a list of really all our successful treatments to date in heart failure with reduced ejection fraction, showing the effect on cardiovascular death in this column, the effect on heart failure hospitalization in the right-hand column. And there's really nothing like this. We've not seen any other treatment where there appears to be more of an effect on cardiovascular death than there is on heart failure hospitalization. But again, I think we probably have an explanation for that, which we'll come on to in a moment. Now, I think most people, when they saw that finding initially. And indeed, I know from speaking to the Victor investigators, they had the same thought, was, my goodness, this looks like an implantable cardioverter defibrillator. That's the only other treatment we know reduces death without reducing heart failure hospitalization. But you can see here that, in fact, the effect of vericiguat in the Victor trial on the two major modes of death was similar. In other words, there was a reduction in sudden death, but there was also a reduction in heart failure death, again, as we see with most effective heart failure therapies. So this wasn't this apparent difference between reduction in cardiovascular death and reduction in heart failure hospitalization wasn't due to a selective specific effect on sudden death. There was a reduction in heart failure death as well. So this, as I say, did puzzle everybody at the Congress. There was a lot of discussion afterwards about it, but I think the answer actually lies in the meta-analysis that was also presented and published at the ESC Congress. So quite reasonably and appropriately, the two trials, the Victor trial and the Victoria trial, were meta-analyzed. And when we look at the meta-analysis, so this is the most robust way to look at the effect of vericiguat, you see here that there was, if you put the two trials together, around a 10% reduction in cardiovascular death, and there was around a 10% reduction in heart failure hospitalization. And I think that actually probably is the true effect of vericiguat. I think that with very large numbers, you can see that there was this relatively modest effect on these two outcomes. And one of the reasons that I've been showing you the effects of sacubitril valsartan alongside the effect of vericiguat is not only because these two drugs both work through cyclic GMP, but also because I think maybe differently than any other treatment you can see in this table, they have an approximately equal effect on cardiovascular death and heart failure hospitalization. With sacubitril valsartan, there's about a 20% reduction in both of these outcomes. With vericiguat, there's about half that effect. So it's like with vericiguat, you get approximately half the benefit that you see with sacubitril valsartan. You get this around 10% reduction in these outcomes. With sacubitril valsartan was about 20%. That's not really true for any other treatment, and that itself, I think, is an interesting finding. If you look at all the other successful treatments in heart failure with reduced ejection fraction, we tend to see a bigger effect on heart failure hospitalization or worsening heart failure events than we see on cardiovascular death. And sacubitril valsartan and maybe vericiguat stand out in having a more balanced effect on these two outcomes than with any other treatment. So just to finish off, the other thing that the Victor and Victoria investigators presented was a further analysis of this apparent interaction with NT-proBNP. So again, this is the continuous hazard ratio. This is now for the two trials put together, and they make the point that you still see a suggestion of an attenuated benefit of vericiguat in patients with an NT-proBNP above 6,000 picograms per mil. So whether that's true or not, I'm not sure. My own inclination is that this is unlikely to be a true biological effect because we've really not seen it with any other treatment. Admittedly, we didn't measure NT-proBNP in many of our older trials because we weren't able to do that, and we weren't aware of the importance of natriuretic peptides. But for at least 2 treatments, we do have NT-proBNP measurements, and we did not see that interaction. So we didn't see it with carvedilol, we didn't see it with SGLT2 inhibitors. I think it's highly likely that in 2 of our older trials in very sick patients with heart failure, the consensus trial with enalapril, the RALS trial with spironolactone, NT-proBNP levels were probably very high in the patients enrolled in these trials, and yet we saw very large relative and absolute risk reductions with these 2 treatments. So I think it's probably not a real effect, although potentially there could be a biological explanation, although I think it's unlikely. And of course, that biological explanation might have been because natriuretic peptides also act through cyclic GMP. Perhaps patients with very high natriuretic peptides already have maximally stimulated cyclic GMP pathways, and therefore adding vericiguat is unlikely to have any additional benefit. Now, that's again perhaps an explanation, but you would have expected to see the same interaction in that case with sacubitril valsartan, with neprilysin inhibition, also acting through cyclic GMP, and we really don't see that. This is tried to draw an identical figure from the Paradigm heart failure trial as we see here in the Victor and Victoria analyses, and you just don't see that same interaction. The 95% confidence intervals around the continuous hazard ratio for the benefit of sacubitril valsartan compared to enalapril lie consistently below unity, in other words, below 1, and indicating benefit across the full spectrum of natriuretic peptide levels. So my own inclination is that that interaction with NT-proBNP is probably spurious. I'm always anxious about doing subgroup analyses of that sort, and I'm really unconvinced that it is a real interaction. And in any case, if it is true, I think we would need to understand it a lot better. Why would people with higher NT-proBNP levels, who tend to be older, who tend to have lower BMI, lower ejection fraction, atrial fibrillation, chronic kidney disease, etc., why would they be less likely to benefit from vericiguat exclusively? We, as I've mentioned, we've not seen this interaction with other treatments. Why would we just see this with vericiguat? It doesn't really make a lot of sense. And also, if those interactions, if that interaction with NT-proBNP, that interaction with hospital admission is true, then what are the implications for treatment using vericiguat? It would become really difficult to think about how to use this drug. Would we have to monitor natriuretic peptide levels? Would we have to stop treatment in patients whose natriuretic peptide levels increase? Doesn't really make sense. So my own inclination is really to look at the meta-analysis of the 2 trials. Now we're talking about very large numbers of patients, very large numbers of events, getting a very robust assessment of the effect of treatment. I think the bottom line here is that vericiguat is an effective treatment, but unfortunately not a very effective treatment. The relative risk reduction with this treatment is, as I said earlier, rather small, around 10%. Now, that's not to say that isn't important, but it's a lot less than the treatment effect that we've been used to with the other treatments that you can see in this table. So that's my own opinion about the results of the Victor trial in the context of the Victoria trial published in 2020 and all the other evidence that we have for the efficacy of drugs in patients with this type of heart failure. And I'm very happy to discuss this further if you would like me to. Thank you very much.
Well, thank you so much, Professor McMurray, for guiding us through those sometimes even, as you mentioned, puzzling results of this important trial. And maybe I can start off with the question that struck me most, and you mentioned that, and it's the question about the strict choice of the primary endpoint, this heart failure hospitalization. As you mentioned earlier, we know that every contact with the GP, every up titration of the diuretic mentions in terms of prognosis. And could you speculate why the authors, why the trialists rather stuck to this conservative endpoint? And shouldn't we, for future clinical trials, shouldn't we always integrate those different parts? Shouldn't we expand this endpoint?
Well, I think we should, but don't forget we've been learning. So as you do trials, you learn. So we published way back in, I think, 2015, that in the paradigm heart failure trial with sacubitril/valsartan, we saw exactly what you suggested. In other words, that it was the fact that a patient had worsening signs and symptoms, and the fact that a doctor felt the need to intensify the patient's treatment that mattered. It wasn't where the treatment took place or where the patient was looked after. It was just the very fact that they got worse and that somebody felt that that worsening required additional treatment. Now that's one trial, so we've now shown this, and others have shown this in at least 5 or 6 other large data sets. So I would say in 2025, we're reasonably comfortable that what I've said, and I was just repeating what you said, I think we're reasonably comfortable that that's true. But I'm not sure that we knew for certain when the Victor trial was designed and implemented that that was the case. It is also the case that the regulators, the payers, and the clinical community, that's us when we're being doctors as opposed to trialists, we're sometimes a little bit skeptical about these expanded endpoints with what some people would call softer components. So there are many, many influences that are actually at play when you're doing clinical trials. And I think the Victor investigators were entirely reasonable in using that harder endpoint, what you might call more conventional endpoint. And indeed, their trial would have demonstrated a benefit with the numbers of heart failure hospitalizations they had if vericiguat had the treatment effect that they hoped it would have. They powered their trial for a 20% relative risk reduction in worsening heart failure events or heart failure hospitalizations. If they'd seen that, if this had been an SGLT2 inhibitor with the number of heart failure hospitalizations that actually occurred in the trial, they would have had no problem in showing a significant event. It was simply because there weren't enough of those events to demonstrate a 10% relative risk reduction in worsening heart failure events.
Thank you for these insights. On saying on that topic, being a trialist or a clinician, that's an interesting formulation of the situation, by the way. I thought, thank you for that. What do you think? On the one hand, you showed the excellent pre-treatment of the patients. I think 59% on an SGLT2 inhibitor. We haven't had that in another heart failure trial yet. Yeah. What's your thought on the reduction of the absolute risk of that? I mean, in Victoria, we had a much larger absolute risk, which apparently we didn't have so much now. You compared the paradigm data. And then coming from there, which is the patient? Who's the patient you will be giving the drug to if you were able to, if you could freely prescribe? Is it the very sick one, which we're doing now? But on the other hand, the very sick one might have a very high BNP. So where are we going in our
So very, very good question. So let's deal with this absolute versus relative risk reduction. So my honest opinion about that was that when the Victoria trial came out, that was I'm not sure that I would have agreed with the interpretation, because I could pick a subgroup of patients in the paradigm heart failure who were at very high absolute risk, but they had the same relative risk reduction with sacubitril/valsartan. So their absolute risk reduction was much larger than in the Victoria trial. So all trials have absolute risk and relative risk, and the absolute risk reduction is simply a function of the risk that people are at and the relative risk reduction with the treatment. So if you enrich your patient population such that they're at very high absolute risk, then of course, if you have an effective treatment, you will always get a large relative risk reduction, but then that tends to be a minority of patients. So I think the bottom line is, whether we like it or not, vericiguat has a small relative risk reduction, but applied to high risk patients, then that gives you a large absolute risk reduction. And I think the second part of your question about who do we give this to depends a little bit on whether you believe those subgroup analyses about natriuretic peptides, or whether you think that that's probably a spurious finding, reflecting what you will often see when you do subgroup analyses in clinical trials, in which we've seen in many, many previous cases. And I find it difficult to believe that is a real interaction. Now, of course, I can't prove that, but as I said in my presentation, it's not true of any other treatment. It's not true for carvedilol. It's not true for SGLT2 inhibitors. I think it is reasonable to infer that it's not true for ACE inhibitors or angiotensin receptor blockers and mineralocorticoid receptor antagonists. And it's also not true for sacubitril/valsartan. And again, the reason I come back to sacubitril/valsartan, if there was any treatment where we would expect the effect to be attenuated in people with high natriuretic peptide levels, it would be sacubitril/valsartan. Because what are we doing with neprilysin inhibition? We're augmenting natriuretic peptides. We're trying to amplify the cyclic GMP pathway in the same way that you're trying to do with vericiguat. And we didn't see that attenuation with sacubitril/valsartan. So I just find it improbable. Doesn't mean it's impossible, but I think it's improbable. So if I was using vericiguat, and by the way, just so that you know, I can't use vericiguat in the United Kingdom because we don't have it available in this country. It was never submitted to our National Health Service payer agency, which is called NICE. But if I had it available, I would use it. I would use it irrespective of natriuretic peptide levels, because my own personal view is that my best estimate of the treatment effect comes from the meta-analysis of the two trials. Simple as that. And if I could get a 10% reduction in cardiovascular mortality, I think that's actually very worthwhile on top of everything else we have available. If I had heart failure, my father had heart failure, would I want to reduce his risk further, even if that's a rather modest reduction? Yes, I would. And if the treatment was available, why would I not use it?
As a kidney doctor, I have to ask you, surely Victor is kind of unique, and you showed that because inclusion criteria went down to 15 mils per minute. On the other hand, people with advanced CKD have particularly high proBNP levels. So following the sub-analysis, they might be those who benefit less. So do you see a particular role for vericiguat in people with advanced CKD, or would that be rather play of chance and rather following inclusion criteria than pathophysiological understanding?
No, I do think, like SGLT2 inhibitors, I think any treatment that we can give safely to, for us as cardiologists, that rather small segment of the heart failure population who've advanced CKD, any treatment you can give to those patients, I think is a huge improvement on all the other treatments, which we generally have to discontinue because they're frankly not safe in some cases. So I think you've made a very, very good point. I think I'm more inclined to believe that this treatment works in patients with heart failure and reduced ejection fraction, irrespective of EGFR and irrespective of natriuretic peptides. And I would at least try and use that treatment in those patients if possible. And by the way, it's also maybe worth stating that there are other agents in this broad class that are under development, including in patients with CKD. So it may be that in the future we will see drugs like this that are not just indicated in heart failure, but may actually have a separate indication in CKD. And it may also be the case that, of course, that a soluble guanylate cyclase activator may prove to have a bigger treatment effect, and in terms of relative risk reduction, it may be possible to get one of these drugs that has a sort of sacubitril valsartan sized treatment benefit as opposed to maybe currently what looks like around half of that benefit. So I would not dismiss the potential of this class in our overlapping specialities, and I would say watch this space, because I know there is, for example, a large phase 2 trial underway with a successor compound in patients with chronic kidney disease.
Well, from the perspective of our viewers, or even from my and Stefan's and Gunnar's perspective, if we try to walk in your shoes or try to see your perspective, I think everybody would be afraid of future clinical trials and would ask the question: how can you dare to perform future trials on top of well-treated patients? And I think, coming maybe to the last question and the elephant in the room, you can, and at least we have seen another trial who was positive, using digitoxin. And maybe as a final point, you could unpuzzle that for our viewers and for us at this time.
So there is lots still to do. In fact, one of the slides I nearly put in, but in the interest of time I didn't, was looking at the residual risk in the dapagliflozin treated patients in the DAP-HF trial. And believe me, we have not cured heart failure with reduced ejection fraction. We've made great inroads, but there's still a lot to do, and we need more treatments. So I was particularly delighted to see the results of Digit-HF at ESC, because I have been a believer in digoxin and digitalis glycosides more generally for a very long time. And I was also delighted because I believe it's actually the 240th anniversary of the publication of William Withering's description of the use of digoxin as a treatment for patients with heart failure. And why was I a believer? Because we have a very large trial called the DIG trial, as you probably know, with digoxin, published a long time ago, looking at digoxin added on top of an ACE inhibitor, diuretics, and in some cases mineralocorticoid receptor antagonists, showing a reduction in a composite outcome driven predominantly by a relatively large reduction in heart failure hospitalization. And in fact, there's a lot more to it than that, because what I think a lot of people have forgotten is that many years ago, when there was a great deal of interest in developing new treatments for heart failure, particularly inotropic drugs, what happened was there was a whole series of relatively modest-sized trials comparing the new treatment to placebo to digoxin. And in almost all of those trials, what happened was digoxin beat placebo, but the new treatment did not beat either placebo or digoxin. So there's what I'm simply saying is there's a lot more than one trial demonstrating the benefit of digoxin. Now, do we think that digoxin works in the same way as an ACE inhibitor, an MRA, a beta blocker? I don't think so. And therefore, there's no reason why the benefit of digoxin wouldn't be additive to those other therapies. And that's what I think Digit-HF shows. So it shows that a different digitalis glycoside digitoxin significantly reduced the risk of all-cause death or heart failure hospitalization. So again, heart failure hospitalization, and there was an 18% relative risk reduction, again, driven predominantly by reduction in heart failure hospitalization. So that is a very welcome addition to all of the other treatments we have, because digitoxin doesn't reduce blood pressure. And one of the biggest problems we have in particularly patients, sicker patients with heart failure, is intolerance of drugs that lower blood pressure. And probably one of the places I most often use digoxin today, because I still use digoxin, is in patients who can't tolerate other drugs because of hypotension. So as I said, I was delighted to see the results of this trial. I think they're consistent with the DIG trial, although the one caveat is that I think just under 30% of patients in Digit-HF had atrial fibrillation at baseline, whereas of course in the original DIG trial, only patients in sinus rhythm were included. So that's maybe one limitation. And of course, there's another trial currently still running called Decision, which is another digitalis glycoside being run out of the Netherlands. So we're going to get another piece of information, and I'm sure in due course we'll see a meta-analysis of Digit-HF and Decision. So I think it's great to see digitalis glycosides coming back, and I think they're a very, very welcome addition to our armamentarium for these patients.
Also always interesting to see the different views, even if we talk about global studies between the UK and Germany in this case. We do have vericiguat, we don't give it so often, but we do. Whereas the digitoxin story, talking with colleagues here, they all come with now it's a 10-year running trial. The curves kind of come together in the end. People weren't pre-treated so well. So they all kind of make it bad and say it's not a good drug.
Well, that's what happens with every trial. So by the way, all Kaplan-Meier curves come together in the end. So this trial had an unusually long follow-up. I believe the median follow-up was 3 years, which is quite long. They were quite sick patients. So all Kaplan-Meier curves come together. So for example, if you go back to the consensus trial, the very first trial to show a reduction in mortality with enalapril in patients with very severe heart failure, because that trial was carried out in Scandinavia, it was possible to do long-term follow-up of everybody in that trial. And if you look at the longer-term follow-up, the 5-year and the 10-year follow-up, you see a beautiful example of that. Of course, all of our Kaplan-Meier curves, sadly, come together. So that, and there are also some issues. I mean, I'm slightly surprised the journal actually let them publish those Kaplan-Meier curves, because there was also the issue of very, very small numbers towards the end of the trial, and that gives you uninterpretable, really, ends to the Kaplan-Meier curves. They should probably have been truncated at 30 months or something like that. So so that's just it's a statistical technical issue. Absolutely no way reduces the importance of the trial, and I think you'd be foolish if you look after patients with heart failure not to want to have a digitalis glycoside available due to use, and I imagine that we will see an upswing in the use of digitalis glycosides. Again, they had become, I would say, less popular than they used to be when I started, and don't everybody does kind of forget, but don't forget in those early trials with ACE inhibitors and MRAs and even beta blockers, up to 80% of people were on a digitalis glycoside. So you could argue that all the treatments that we have were actually treatments that were shown to be a benefit used in combination with digitalis glycosides. So I think this is an important breakthrough, and I think that will be reflected in the guidelines as well.
Maybe as a last question from my part, which would be the timeline? You alluded to some novel drugs that are now under development based upon these earlier results, like natriuretic peptide receptors, PDE9 inhibitors, which I learned from earlier talks from you, actually. So when will we see the next really phase 3 study? And will all this be then additive? So from these, I'm aware not everybody likes this Fantastic Four, and I think you prefer the nice 5 or something like that, and 5. And now if you add digoxin and iron and maybe even 7 or whatsoever. So will you finally, you as cardiologists, tell us non-cardiologists to have 7, 8, 9 drugs?
Well, you have your own pillars of therapy now. You've got lots of treatments. So there is an issue. I mean, there's no question that there are potentially too many drugs for people to take, and there are various ways that we will have to think through to move forward. So there are those who believe that we should be trying to replace drugs, and that is ethically difficult, but there is a parallel. So in heart failure, we also use devices. We use implantable cardioverter defibrillators. They've been shown to reduce mortality, but there are now 2 large trials underway, one even in North America, looking at ICDs again and whether there's still a role for them. So randomizing patients with the type of heart failure we've just been talking about to getting or not getting an ICD. Now, I actually didn't think that would be possible, but we're doing those 2 trials. So maybe we will start to think that way about drugs as well. Another approach, of course, is to try and target treatments to those who have most to gain from a particular treatment, so personalizing treatment. I'm not sure how to do that. And I have to say my own preferred option is the polypill option. I think the time really has come to think about a polypill for heart failure, and more than think about it, because I actually know of 2 trials that are currently underway studying a polypill in heart failure, and I don't see why we shouldn't do that. We do it routinely in hypertension. I could imagine you could do it in nephrology as well, and we should do it in heart failure. And really, if all of these new treatments that are currently in the pipeline are going to show some benefit, we will have to do something like that, because I don't think we can have 7 first-line heart failure treatments, because our patients don't just have heart failure, they have diabetes, they have atrial fibrillation, they're on anticoagulants, they're on glucose-lowering therapies, they're on so many treatments. So somehow or another, we have to figure out a way to rationalize it.
Well, John McMurray, thank you so much. I think the 3 of us could be talking with you, I think, for the rest of the night.
I don't want to do that.
More of your time.
Less about football. But...
I mean, really, thank you so much. This has been excellent, and giving us so many insights into your thoughts and all your experience and the many clinical trials you oversee. We are very grateful for that and honored that you joined.
Thank you very much. Well, thank you for inviting me.
and we do hope that maybe with the next things to come, maybe we get the opportunity next year again to possibly talk to you. So thank you very much indeed.
Okay. Bye-bye.